Okay, so hello everyone. Welcome back to SME Symposiums. I think we're still waiting for quite a few more people to join, but for the sake of punctuality, I will get moving. So welcome. Today's webinar is going to be about internal medicine specialization in the UK. I've been waiting quite a while for this one, and I think quite a few people have been asking for it. So quickly, before I do hand it over, I'm just going to go over the nitty-gritty details. So as you guys know, we do these every month and we have monthly webinars, and really the concept is to, the whole project really is dedicated to keeping you updated on relevant and important medical topics. So everybody's welcome and it's completely free. We also give a certificate for attendance when you fill in the feedback form, which I will share with you all at the end. And we will have a small Q&A section at the end. If you guys do have any questions, please do feel free to ask them in the Q&A box. You'll see that at the bottom, or take a note of them and send them to me, and I will ask the doctor them directly at the end. So today our speaker will be Dr. Iman Abdul-Khaliq. I have worked with Iman. She is an absolutely amazing doctor. You guys are in for a ride because she's just got so much to give that's outside the spectrum of standard medicine, and a real hardcore and just sort of a real concept of what it really is to work in medicine, and especially in internal medicine. So I'm really excited for the speaker to be on today. And quickly, before I do hand it over, this is today's program. So after me, Dr. Khaliq will be coming on, and then we will have a quick Q&A at the end. And of course, a big thank you to Lectorio, which is an all-in-one study resource for medical students that combine learning, science, and medical education into one easy-to-use platform. I know you guys have heard me say this every time I have a webinar, but they are really good. And they're also our sponsors, and I think you guys should really go and check them out. We will send you a 50% discount code at the end. And I think we have a couple of 6-month passes to hand out as well. So I will do that at the end for the ones who do fill in the feedback form. Okay, without further ado, I'm going to hand it over. Thank you all so much. Good luck, doctor.
Hi, guys. Let me get this working. Oh, don't do that. Can you see it? The presentation?
You can see it.
Lovely. So hi, everyone. Thank you for coming. My name is Iman, as Mohsen has very kindly introduced me. So I am an IM3 or an ST3, depending on what you want to call it. And I wanted to kind of do this talk to tell you guys what medicine is really like, and to tell you that medicine is awesome and that you should actually think about it. So I want to start with a bit about me. I want to go over kind of like the human factors around being medicine, because people don't see medics or doctors as people anymore. Just want to let you know that what I'm like as a person. So generally, I'm somebody who's got a really relaxed attitude. I like to chill out most of the time. This is specifically outside of work. I like to simplify everything that I go into, because I think when you simplify something, everything makes sense. I tend to be able to deal with stress pretty well most of the time. I can be like dying inside, but it won't show, which is a good thing. I have an extroverted personality, and I kind of wanted to go through what you guys will think a typical doctor is. So people think that doctors don't have lives. People think that doctors only do their work. And it's really important that you get from this webinar that what is important is you have a life and you are a person, and medicine is full of different personalities. So a little bit about myself and what my journey was. So kind of went through sixth form, doing your A-levels, and then I wasn't born with this innate idea that medicine was for me. It was in sixth form where I realized I actually enjoy human biology. I enjoy science, I enjoy talking to people. So I thought medicine's probably the way I want to go. Got into medicine. I went to St. George's, which is in Tooting in Southwest London. Did the 5-year degree. I did not do a BSc. And then at the end, Well, during med school, what I felt was probably because I want a relaxed life, I want to go for GP. Saying that now, GP is not necessarily the relaxed life, but that is what I was thinking at mid school. And then you're expected to apply for the foundation program as a UK grad. So what was important to me was geography. So something that's close to home, something that I could commute to. So I picked Basildon, which is near enough my house. My first rotation was in general surgery, cardiology, and trauma and orthopedics. And as you can see, it's pretty heavy in the surgical year group with your gen surg and your trauma and orthopedics. It was a good year, and it was a year where I realized actually I want to stay in hospital. And then in F2, I went into Southend, so a completely different hospital, and I did geriatrics, which is medicine of the older people, and I did obs and gynae, which is like your women's health, and pediatrics, which is children. After that, I applied for, I knew I wanted to do hospital medicine, and it was either surgery or medicine for me. And I was just talking to Mohsin about this actually. So I saw people going on their off days to theatres, and I thought that is not going to be me. And then I thought medicine, because medicine has everything that I want in it. It's got your practical elements, it's got your thinking elements as well. So I thought, let's go for medicine. I got my first choice. I decided to do it in Basildon because that's where I did my F1, and I knew that the training's pretty good. So I went down that route. As you can see, I've got a whole load of medical rotations here. So in my IMT 1 and 2 year, I did stroke, I did cardiology, I did intensive care for 7 months. So I had a 4-month rotation in intensive care. Then the pandemic hit, so then I got to stay an extra 3 months, which was absolutely amazing. I learned a lot. I did renal medicine, which is like nephrology or kidneys, gastro, and respiratory. In yellow here, I've got that I was the IMT2 rep. So it's important that if you have an opportunity to do any form of rep work, do it, because it goes in your portfolio, it goes as leadership skills, and it makes you look like a beneficial person to whatever job you're going to do. I then was doing my IM3 year, which is what I'm at now. So this is the year as a general medical registrar. I was a bit anxious starting, but it's going really well so far. I'm doing it endocrine and geriatrics. I'm also currently the medical registrar rep in my hospital, and I'm the associate college tutor, which means I sort out education for other doctors. Just putting it out there, I'm not the type of person who goes out of my way to become a representative or to do these posts. I mainly do them because I want to see change. If there's I've heavily been involved in changing the rota, so it was something that I felt was important to me. So get involved if you can. If you're not, it's fine, it's not a big deal. And then the question is, what do I want in the future? So I really enjoyed gastroenterology, so working with the GI tract. I like working with people who have decompensated liver disease, people who have bleeds. It's pretty interesting. And then I probably will do a dual accreditation with intensive care because I liked intensive care so much. This is, again, the human factor. So I want you guys to know that us as doctors, or you guys in the future as doctors, or as tomorrow's doctors, we are humans, we have lives, we need to have a semblance of something that keeps us away from the world of medicine, something that allows you to escape, if that's a word. So this is some of the things that I do outside of medicine. So I enjoy football, specifically the Premier League. I have my own fantasy team. This over here means come on you Iron, so I'm a West Ham supporter, for those of you who didn't know. I love food. Food gives me joy. I love going to restaurants with friends and family and trying different things. In the last 2 years, I've taken up cycling. I used to be pretty sporty back when I was in school, and then it just kind of stopped from medical school onwards, and I just wanted to have something where you can still get the adrenaline rush, so that's what I'm doing at the moment. I do play games. I play PS5. The last games I've played have been Assassin's Creed Valhalla and Spider-Man, Miles Morales. I watch anime, I watch lots of movies. I try to go to the cinema like every week if I can, barring the pandemic, obviously. Charity is really close to my heart. I enjoy taking part in charity. 2 years ago, I went to Africa, to Gambia, for a charity trip, and that was pretty good as well. I do lots of teaching, so medical students and junior doctors as well. And I'm a school governor of the school that I used to go to, which is a different aspect of school life. But yeah, the important thing I want you to take from this is have a work-life balance. You talk about it when you're going into medical school because it's part of your interviews and it makes you sound very good, but it is an important factor of being a doctor. So this here is the training program. So this is what it looks like to go into medicine specifically for Group 1 specialties. I'll talk to you about what Group 1 and Group 2 specialties are, but in essence, you start off with your foundation year. So you, as a UK grad, you'll do F1 and you do F2. F1 is the year that you have provisional registration with the GMC. At the end of your F1 year, you get fully registered. As IMGs, you guys get GMC registration when you apply for it. So you can start as an F2. We'll talk about that in a minute. And then you'd go through an application process, so a selection process where you say, okay, I want to do medicine. And then when you decide to do that, you do it for 3 years, specifically for Group 1 specialty, and 2 if you want to do a Group 2 specialty. Within these years, you need to fulfill this MRCP. So the MRCP is the exams, so it's 3 exams. So you do part 1, part 2, which are both written exams, and then PACES, which is a practical exam. Once you've completed that, you have full MRCP accreditation and you can then apply for specialty training. You have to, again, go through a selection process. So you go through interviews, you fill out an application on ORIO, which I'll show you. And then you do your specialty training. Your specialty training will be in a medical specialty of your choice. So if you want to be a cardiologist, go for cardiology. It's now a 4-year training program, so is all the others. And then after that, you have to sit your specialty exams, and then you go through to become a consultant. So the one in yellow is where I am now. So like I said, this is more of a diagrammatic representation. So you get your full GMC registration after completing your F1 and F2 years. And then you are going to decide what you want to do. So pick your group. So do you want to do GP? Do you want to do medicine? Do you want to do surgery? Or do you want to do more of a specialist-based approach? So do you want to go into something like a run-through program like ophthalmology or radiology? You don't necessarily have to go into F1 knowing what you want to do, but if you do, you can guide your training. I had no idea what I wanted to do. Actually, when I was at the point of F1 and F2, I just had decided I want to work in a hospital. And in F2, I just decided, let's go for medicine. And I have not regretted that decision since. When I chose medicine, you have a whole range of medical specialties that you go into. And it's either 2 to 3 years, and then you have to do your MRCP competencies. In your IM3 year, you're now a medical registrar. You're going to be on the registrar rota. People will be calling you for advice and things like that. You apply over here for your specialty of choice. So you do your registrar training. Within this, it lasts 4 years. You pick the specialty that you want to go into. So for me, my life will be around gastroenterology because that's what I've applied for. And then you do the specialty exams here. And then after that, you go in and you become a consultant. As a consultant, you are the specialist in that field. People will come to you for advice all the time. You'll be taking care of your own patients. They'll all be under you and you will have the responsibility. Ultimately, you're going to be a consultant for at least 20 to 30 years of your life. So you've got your Group 1 and Group 2 specialties. So in medicine, Group 1 specialties will go for 3 years of training and Group 2 specialties will have 2 years of training. So the Group 1 specialties over here are, if you're interested in them, is you do 3 years of the medicine program. And the idea behind that is that you're going to do an extra year because you're going to remain on the on-call rota. So you're going to do general medicine alongside whatever specialty you choose. So if you wanted to be a cardiologist, you will do your specialty, but every month or so you will go onto the on-call. So you'll do nights, you'll do the take, and you'll do general medicine. The group 2 specialties, so you end up doing 2 years of medical training and then you just go straight into that specialty and you do not do on-calls in general medicine. So you can see things like dermatology, hematology here. So a good question that people can ask is, can I take a break? Of course you can. So like I said, medicine doesn't have to be your whole life. You can take breaks at any point. You can go through something called less than full-time training, which is the same training program, but a longer period of time because you're not doing every day. So you can choose to do 60% or 80% because some people will have families, some people have children. Not everyone's the same age and people have different circumstances or people to care for. You can also take gaps in between training. So you can decide, I'll do my F1 and F2 year, and then I want to relax, I want to locum. So locuming is when you decide what days you work and what specialty you want to work in, which wards you want to work in, which on-call dates you want to do. And you get paid by the hour, and it's a drastic difference from what you're getting paid in training. So an example would be if your minimum wage is like £15 per hour as an F1, you'll earn around £30–35 per hour as a locum. That's for an F1. It goes up as the grade goes up. You can also tend to take a break here. So you've done your SHO training, and then before you go into your specialty registrar training, you can take a break here and then do something else. You can decide that you want to do research. You can decide that you want a year out where you can do a fellowship in that specialty that you're interested in, or you can just locum again. You can also take a break after your registrar years, and within this year, you can decide that you want to do research, you want to do like a research fellowship or a master's or a PhD. To be honest, you can take a break at any time in this whole bit of training. There's not one rule for anyone. So the idea behind this is that you can take a year out, you can take 2 years out. There's a guy in my year when we started as F1s who's still currently, I think he's an F5 or an F6 now. And so he's like here in his training, whereas I've hit here. But there's nothing wrong with that because he doesn't have an incentive to go into training. He doesn't know what he wants to do, but he wants to save up, get money, get a mortgage, get a house. So you will have different priorities at different times in your life. So this at the top is what the ORIO website looks for. So ORIO is the website that will be for all of your applications that you'll be using for everything. So you'll be using this for the UK Foundation Programme if you want to enter the UK FPO, and then also for internal medicine training, for surgical training, and then even further than that, it goes on and you can apply for your specialty programmes. So you'll see this a lot in your lives. This at the bottom again is another representation of what training is. So you decide to do your F1 and F2. If you take a year out, that's fine. You can then apply whenever you want. You can go through a run-through specialty, so like your ophthalmology, your radiology. You can decide to do anesthetics or emergency care, and then you can do surgical training. So you do CT1, CT2, and then registrar training, and then you've got internal medicine training, so IMT1, 2, and then you're either IMT3 or ST3, depending on if you're a group 1 or group 2 specialty, and then going through your registrar training. So I'll go through what it was like for me. So the jump to F1 can be very steep. So, and it's not just F1. For you guys, it will be your jump going to F2 if you decide to do an F2 straight away. The jump from your first year as a doctor can be very steep because, let me put this into perspective. You're that medical student who comes to the ward, does the ward round, and you might do, I don't know, a blood test or something. You might help out with a discharge summary. And then there's not much gone on the ward. So then you decide, oh, I might as well go. So you leave, and that's okay. And then the next day you might help with a blood test. You don't get the blood test. And then you just give it to the doctor and then you leave. You can't do that as a doctor because ultimately that responsibility is now yours. And that responsibility shift can be very daunting because if you don't do it, nobody's going to do it. So I was actually terrified when I first started, and I think everybody is, and it's really nerve-wracking. But ultimately you learn as you do the job. My mindset at the time, like I talked about, was I want a chill life. I want to do GP. Having said that, GP is not going to be your chill life. You do have nicer hours, so you don't have to do like nights or weekends if you don't want to. But I wouldn't call it a chill life anymore because primary care is changing. I started off in surgery, so it allowed me to become quite organized and sort out life in terms of like radiology, getting scans, looking at scans. And I found that I really enjoyed working in a hospital and that actually I wanted to stay in hospital. So what are your requirements as an F1? So as a UK, I'm going to put it down across as UK graduates, and then I'll go through the IMG option as well. But for a UK graduate, if you start on from an F1, you need to obviously pass medical school. And then as long as you pass, you'll be fine. If you don't pass, it's okay. Just keep resitting them until you do. Because obviously you haven't wasted 5 years of your life for nothing. You have to sit an SJT exam. So the SJT is a situational judgment test, which is all about giving you scenarios or ethical scenarios and seeing how you would react to those. You can also do a prescribing exam. So this has to be done by the end of F1, but most people actually complete this by the time they finish med school. Once you've done that, so you get a point, it's a point system, so you get scored, and depending on your score, you can rank on regions. So if you're like the top candidate in the whole country, you will get your first choice. After that, you will apply on ORIO. So this is still when you're in med school. You apply on ORIO and you pick what you want and you rank the regions. So for me, geography was important. I wanted something that was close to home. So that's what I did according to that. And obviously certain deaneries or certain places are going to be a little bit more competitive. So if you want to work in London or around London, it's going to be a bit more competitive in comparison to somewhere at the bottom of the country. Everyone has to complete F1 to get full GMC registration, because you start off with provisional registration, and at the end of the year, if you pass your competencies, you get full GMC registration. For you guys as IMGs, you will have GMC registration when you apply before coming here. And you can enter as an F2. And I've put here, is that the best option? And I'll answer the question in the next slide. Throughout your life as a doctor, you have to have a portfolio. So if you're an F1 and F2, you use Horace. If you're above, like you continue your training, you use NHS portfolio. The Horace portfolio, so the whole point of a portfolio is you document what you've done. So if you've done loads of procedures, you would be putting those procedures in. So I've done lots of cannulas, I've done lots of catheters, I've done lumbar punctures, things like that. And then that goes towards the competencies. You can also do work-based clinical assessments. These are what we call mini KEXs and CBDs, so case-based discussions. And you can also put down reflection on events. So they can be positive things like you found a patient who was in cardiac arrest and you led the cardiac arrest until the registrar arrived. Or you can put down things that you've learned from. So you accidentally prescribed the wrong drug and what you learned from that. You get given an educational and a clinical supervisor. This is a consultant who is ultimately in charge of your training. And if, for example, you're struggling with something or you need advice and you can't get it from your direct seniors on the ward or the placement that you're on, you can always go to these guys, because more often than not, they have had similar problems with previous candidates before. So they can always help you out and they'll always have your back. So for you guys as IMGs, so you guys will apply for GMC registration. For this, you need to complete a series of exams depending on what route you decide to take. So some people will do the PLAB exam, some people will do the USMLE, like it just kind of depends where you're coming from and what is expected and what route you take. Obviously, you have to complete medical school and it has to be accredited by the GMC, so they approve it. And then you have to complete the IELTS. Now, the IELTS is an English proficiency test. So it's all about saying that you can work with the English language and you know enough of it to be able to work in an English hospital. You can get your competencies either in or outside of the UK. So within the UK, you do it in a trust grade post. So you can do it as a standalone F2, which is a non-training job. Or you can start from F1. You can do an F1 trust grade post because you feel like if I start as an F2, I'm going to be seen as slightly senior in comparison to an F1. If you start as an F1, you're on a level playing field because everyone in your year group is going to be new to this. But if you feel confident and you've done placements and you just want to get on with training, you can start from F2. Once you've done that, you can then also do fellowships. So these are extra years added on. So after doing that, you also need to get a CREST form. So the CREST form is signing off by a consultant. It's a form that you fill in, and it's to say that you have got your competencies after they've seen you for 3 months at least on the job. You can apply, some people can, instead of going through the trust grade route, they can apply for the UK FPO program, so the normal F1 and F2 that UK graduates do. So it kind of just depends on what route you take. But you would get full GMC registration in comparison to the UK graduates who have to do at least an F1 year first. So what do I apply for? Now, obviously I'm biased when I say this. I think you should apply for medicine because I love medicine. I think it's the best. The reason I think it's the best is because it offers such a huge, wide variety of different specialties and different personality types. You'll find something for yourself. So if, for example, you're somebody who loves looking at blood tests or looking at things in front of you and diagnosing from that perspective, be a nephrologist, a renal consultant. If you like doing practical procedures, so if you like putting in drains, you can do like respiratory, so lungs, chest medicine, or you can decide that I like putting in ascitic drains and I like doing upper GI bleeds and endoscopies, then you can go through gastro. The reason I love medicine is because you get to do lots of problem solving. So a patient comes in through the front door and they say that they have chest pain. You do the full workup of figuring out what you think it is. So from that history that you have conducted, from that examination that you have done, what do you feel it is? You get to figure out what your differential diagnosis is, order some investigation, see if you were right or see if what you could learn from that, and then management. Sometimes if your first line management doesn't work, you can try something else, and more often than not, it will work. You get lots of patient interaction. So if you like talking to people, it's the one for you, but also you can have less patient interaction in different parts of medicine if you don't like talking to people. You also get to deal with acutely unwell patients. So this is what I really enjoy. So people who are very unwell or very unstable, and then seeing the direct effect of you giving them certain medications or certain therapeutic options that you can deliver. So you can put in a drain in someone who's acutely desaturating. It makes such a huge difference. And then you can see them get better in front of your eyes. Obviously, if they're deteriorating, you can't do anything more, at least you can see it happening. If you don't like the acute aspect of things, there's also the chronic side. So if you have somebody with IBD like Crohn's or ulcerative colitis, you can follow them up. So this is where you build a relationship with these patients. So people that you've seen for 10 years who have Crohn's disease, you monitor what their diet is like, you monitor if they have any complications of the disease or any extra manifestations like joint pain or something like that. So you can see that there's an acute side of medicine, but there's also the chronic side that you can follow up. It's also just lifelong learning. You'll be learning something almost every day of your life. You learn on the job, you learn everything. Things that you don't even think about as a doctor, you will start to learn. You get interpersonal skills. You start to develop communication skills when you're part of an MDT as well. The practical aspect. So if you want practical procedures, there are loads of specialties that give you that. So you can do respiratory, so the lung medicine, where you get to do chest drains, you get to do bronchoscopies, gastro, or you get to do endoscopies or colonoscopies or flexi-sigs or ERCPs. You can do cardiology, where you can do PCIs or inserting pacemakers. So there's huge scope for medicine. You can do things that is completely away from practical procedures, or you can do things that involve that. So do medicine. But having said that, I want everyone to go in this with open eyes, completely be aware of what you're getting yourself into. Because the reality is, as good as medicine is, it is very long. It is very grueling in terms of the hours. You will have people who are non-medics that are your friends or your family, and these people are going to have a 9-to-5 job. They're not going to be working weekends per se, and they're not going to be doing night shifts. But then there you are doing all of those things. I've put this line here: work never really leaves you. And what I mean by that is, I'll give you a personal example. So when I started off on surgery, I'll start on surgery because that's what this happens very early on in your training. I had a patient who had gallstones, and you tend to do an ultrasound or an MRI scan, so an MRCP. And after doing that, you decide what to do, like if they need their gallbladder out or whatever. And I went home, and in the middle of eating dinner, I randomly thought to myself, did I order this patient's scan? Did I not? What did the scan show? And then I was thinking to myself, it took me a second, but then I was like, why in the middle of dinner am I thinking about this patient's scan? Like, I couldn't think about that tomorrow, or somebody else from today can have a look at it. It won't leave you unless you have an escape. So your home life, your social life needs to be your escape. And you learn this as you progress through your training, that you can actually leave work where it's meant to be. If there's urgent things, hand it over to someone else, because there is always somebody taking over from your shift. You get exhausted really quickly. So when you do like 7 days in a row, or very long days, like 3 long days altogether, like 12-hour shifts, you can get really, really tired and exhausted. So you need to look after yourself, because there might not be somebody out there looking out for you. So the only person who can take care of yourself is you. The pay. So I don't think anyone becomes a doctor for the pay. Obviously, there might be some people, but you're not going to get paid huge amounts. You're getting paid pennies for the amount of work that you're doing, especially early on, because I mean, most people will end up staying late. You shouldn't be, but when you're getting to grips with the system, you will be staying a bit longer than normal, and your pay is minimal, man. But as you progress, your pay starts to get better. But that's why people start locuming, because they want to make more money, and it seems like the better option. Make sure you maintain a social life. Like I said, your friends and your family and people around you might not necessarily understand what it's like to be a doctor. They might not understand that you have on-call shifts. Say, for example, it's your brother's birthday. Obviously, you don't want to miss it. But if you're really, really organized, you can arrange swaps and you can get annual leave. I mean, this year I'm working Christmas. So for somebody, if you were celebrating Christmas and you ended up missing a holiday that's really important to you, so it can be Christmas, it could be Eid, it could be Diwali, it can be whatever, but these things you have to be really organized to make sure you're not working on those days. And if you are working, you need to arrange a swap of some sort. So just be really organized. There's solutions for each of these problems, but you only realize that these are problems once you start working. What I want you to understand is that medicine is not all great. A lot of people leave medicine because they didn't think about these options. But if you go into medicine knowing that these are the problems and you have solutions to them, or you start to find solutions, you'll be fine. Like I said, it's all okay if you love medicine. If you love what you do and you find that you love your job, you'll be okay. You will find solutions. It's not necessarily work all the time. You are human. You need to rest. You need to have a social life, and that's what's expected of you. Know that everyone is struggling. If there's a certain aspect in life that you're really struggling with, there is probably someone out there who has suffered the same thing or a similar problem, so you can always talk to them. It's okay if you don't have a career pathway in mind. I was not born with the innate idea that I wanted to be a renal consultant, for example. I didn't even know I wanted to do gastroenterology until this year. I enjoyed everything that I did, so I was very open-minded when I went into training. So I kind of enjoyed every specialty, but then I decided I wanted to go into gastroenterology. So it's okay if you're in med school and you don't know what you want to do. If you do, I mean, that's great, because then you can just tailor your training to what you want. But if you don't, it's never a negative thing. Just remain open-minded and it will come to you. Life as a doctor means you're going to constantly learn something new. There are always new guidelines. There are always new treatment options available. There's always like research that is always happening and things are always changing. So learning, lifelong learning is definitely a huge part of being a doctor. So overall, what I'm trying to say to you guys is that there's the positives of medicine. It's very, like, there's lots of gratification in being a doctor, but there are things that you will pay for in life, but you can work around it if you have your mindset. So I thought what I would do is kind of go into a day in the life. So what my life involves. So an NWD means normal working day. So on a normal day, so this is where I normally start 8:30, finish at 5 o'clock. So I will start off a board round. Board round is when you're on the ward and you kind of quickly screen through all the patients on the ward. And you have a nurse present, you have a physiotherapist, you have an occupational therapist, and obviously the doctors. And then what you can do is go through each patient and find out if something happened overnight or something happened the day before when you weren't around, and if there's any updates. And then you can kind of like get through each of them before you do the ward round. I ensure that there's no sickies on the ward. So if there's any sick patients, of course, then it's flagged up in that ward round, and then I can go and see that sick patient first. And then any new patients who arrive onto the ward, all new patients are seen by the consultant, but if you prepare them first and you go through that patient, it's always easier and quicker. And then what you can also do is the rest of the ward round. So in the morning, if I'm not in clinic, so there's two options. I'm either doing the ward round or I'm in clinic. If I'm in clinic in that specific specialty, so currently I'm on endocrine, so I would have a clinic that runs from 9 o'clock to 1 o'clock. If I'm not in clinic the whole morning, so a couple of hours spent doing the ward round, so you go around seeing all of the patients in the ward, and some of them will be new patients, so you're starting from scratch, but a lot of the patients will be there that you know them from yesterday. So like, you know what's going on, and then they might have had the CT scan that you booked, and then you can work from there or monitor the progress. If the patient's got a chest infection and you started them on antibiotics, have they started to get better? Or do you need to maybe switch around the antibiotics? After ward round, it generates jobs. So for example, say you have a patient who has a pneumonia, but the pneumonia is not getting better and you want to get the lung physicians involved, then you send lung referrals. If you need to do a certain procedure, so if you've got ascites and you need to tap the ascites and get a sample from that, you can do that as well. Like, so you complete all your jobs at that point. If there's any bloods, any cannulas, things like that. Then you go off for your lunch. There's no structure when you're a doctor that says 1 o'clock is lunchtime, okay? A lot of people, there are days that I ended up having lunch at 3 p.m. Sometimes I didn't even have time to have lunch. You need to make time for your own lunch. And now where I'm at now is making sure that not just me getting lunch, but also my juniors. You have your lunch, then you come back to the ward. And again, so for me, when I come back to the ward, I make sure that everyone's happy, the juniors are happy, they're not struggling, there's no sick patients around. And if there's any procedures to get done, I do them or I supervise them. So if there's a lumbar puncture or if there's a drain that needs doing, what we do is something called do one, was it C1, do one, teach one. Which is a good way to go and learn about procedures. So if there's lumbar punctures, there's ascitic drains, there's chest drains, there's cannulas, there's catheters, there's huge scopes of procedures. And obviously me working at the level of registrar, I would be going to see referrals. So if somebody is asking for advice for the specialty I'm on, so I'm on endocrine and somebody sees, I don't know, a hyponatremia or something and they want advice, I would go and see that patient and give them the advice. And then you finish at 5 o'clock, you go home and then you come to work the next day. On-calls are slightly different. So your on-calls are when you're working longer periods. So you're either working like 12.5 or 13-hour shifts. So the on-call, you start at 8 o'clock in the morning, you go to handover. So handover is where everyone in the night team is there and the people who are taking over in the day team are there, or vice versa if you're talking about a night shift. My job as the registrar is the team leader, so I need to make sure that I have everyone available, I'm fully staffed. I go over any sick patients that I need to know about because more often than not, those are the ones who will deteriorate again. So it's important for me to be aware of them. And then if there were any medical emergencies or cardiac arrests that I need to be aware of, they mention that. So it's all a handover of information. So during the on-call, the main job is clerking new patients. So this is admissions from A&E. And that's how you enter the hospital. The good thing about this, I really enjoyed clerking. I loved clerking since I was an F1 actually. So from your F1 job, you get to see new patients, completely new patients. You will go and see that patient. They'll say it's referred as a chest pain. You go see that patient and then you do an examination. You find out that they are desaturating and they have a JVP up to like their eyeballs. And they have bilateral crackles when you listen to their chest. So those things, and then they've got pitting edema in both their legs. So those things give me a differential diagnosis. And then I think, okay, this is heart failure. And then what investigations would you do? So based on your knowledge from med school and from obviously when you're working as a doctor, you will order investigations according to that. So I want a chest x-ray. I want to see what their BNP is. I want to see what their electrolytes are. I want an ECG, things like that. And then you sort out a management plan. I want to give furosemide or like whatever your investigations and management will be. The good thing is, especially in your junior years, consultants are always available to post-take. So that means they will go over that patient with you. So you've made your diagnosis and your plan. The consultant comes around and either agrees with your plan or gives you feedback and says, actually, we could have done it this way. And then that's an excellent opportunity for you to do a work-based assessment, but it's also an opportunity for you to learn and see what they've done differently. For me personally, I see patients in resus. These are the sickest patients who require more senior review. And these are very unwell patients, which is really interesting. I also hold, well, the whole team on the on-call team holds the emergency bleep. So the emergency bleep means you go to all peri-arrests or medical emergencies or cardiac arrests. The registrar is usually the team leader, but any doctor who has done ALS can be the team leader, which is good fun. It's very enjoyable, and it's very stressful, but it can give you so much learning in that period of time. Because one day you might be the doctor who's left with that patient alone. I also see medical referrals, so other specialties like surgery, surgeons will call for advice. They have a patient with chest pain or a patient with a heart rate of 160, what do I do? I'd often either give them advice on the phone or I'd go and see the patient. And then by that time, it's really knackering. I'm not gonna lie, the on-calls are very long and very tiring, but like I said, they're enjoyable to an extent. And then at 8:30, it's evening handover. I hand over to the night team. So again, the same thing we did in the first handover. You let them know that about the sick patients, about any emergencies or cardiac arrests, and make sure that they're fully staffed. And then you go home, ready for the next day. So what can help you prepare? I just want to put things out there. So what can you guys do? Talk to people. So you're here already listening to my experiences, but talk to people who have had similar experiences or are going into the training aspect that you're interested in, because chances are they've been through something similar to you. If it's not similar to you, they'll know somebody who might have gone through similar circumstances. Get a placement, especially as IMGs. My biggest piece of advice is try to get a placement or shadowing in a UK hospital, because that will allow you to see what it's like to work in an NHS hospital, see how the team works, see what the IT systems are like, because that is going to be the biggest hurdle that you have to face. You can even think about getting an F1 trust grade post, if not an F2, and familiarize yourself with that system, see how the NHS works, because that will just make it so much easier for you to work as a doctor. Attend courses. So more often than not, when you when you start in a hospital and they have inductions, they will do things like ATSP, which is asked to see the patient. So they go through common emergencies or common bleeps that you're called for. So if you're called for somebody who's seizing, what do you do? If you've been called to see someone who's had a fall, what do you do? There's also courses for preparation for F1. If it's not available at the hospital that you're going to, I'm sure like it's just a quick Google search and you can do it. And then opportunities in med school. So publications, presentations, audits, and QIs, we'll go over that in a second. The thing I want to say about opportunities in med school is that it's okay if you don't get any of these things. If the opportunity arises, take that opportunity. But I didn't do any of these things in med school and I've gotten this far. So don't worry if you can't get them, but if you can get them and you see the opportunity, do it, because it can only be positive on your applications. Practical tips that you guys can do now. So the most important thing of being a medic or being a doctor at all in this place is knowing how to do an A to E assessment. That is what you will fall back on, if anything. Okay, so if you see a patient is unwell, A to E assessment. If you see a patient is desaturating, A to E assessment. So you look at the airway, you look at the breathing, you look at the circulation, so the heartbeat and things like that. Yeah, you just work systematically and you'll be fine. And you need to start seeing that in the patients that you see. So if you're going to hospitals, going to placements, do a quick A to E assessment, because it makes you think about things. Shadowing and placement, so I've talked about that already. So try to get an experience in a UK hospital to see how it works, because you don't want it to be a big shock to you when you first start working. Obviously get through med school, focus on medical school. Like, you don't need to be worrying about publications and stressing about it, because you don't necessarily need it. It's a bonus, but don't worry about that. Just worry about getting through medical school right now. And then obviously polish your procedural skills. So as a medical student, you guys are able to do things like bloods, cannulas, and catheters. Do them. Like, don't say I've done one, I've got signed off for it, it's fine. As an F1 or an F2 or even more senior, you're going to be called for the cannulas that perhaps nurses can't do. So it's better that you start practicing now, because you'll only become better. So applications, I'm going to quickly go over this because this is quite far away from where you guys are, but applications is what can help you get the job. So these are the actual subheadings that are involved in your applications, both as when you're going into medicine training, but also as a specialty registrar. So if you're like top, I don't know, 10% or 20%, and you can get a certificate for that in med school in any of your years, you're going to look amazing. If you have any prizes, that makes you look amazing. If you have any postgraduate degrees, so if some people would have done like biomed or pharmacy before doing medicine as well, that makes you look great. Some people do PhDs and masters as well. You can do presentations and posters, you can do publications. If you go to a placement and all you need to do is ask the registrar or the consultant, is there any audits or any presentations that I can be involved in? And actually, more often than not, there's always something to do. All you need to do is a bit of data collection, and it's easy for you to get involved. Publications, teaching, get involved, teach medical students lower in your year group, again, and get like a certificate for it, because it will be beneficial for you for when you start applying. Audits and QI, again, easy opportunity for you to do some data collection and get your name on there. Commitment to specialty. So if you know what specialty you want to do, it's easy because you can tailor your whole portfolio to that specialty. If you don't know, that's fine, because that was me. Just do a bunch of different specialties and I'm sure you'll find what you like. But as long as you show that this is medicine, I want to do medicine. Get involved in courses or memberships. So if I'm interested in gastro, I will get involved with the BSG. If you're interested in respiratory, you can get involved with the BTS. Like, there's lots of different societies that you can get involved in. And as a medical student, a lot of them are free or very low cost. And attend courses, because all of these subheadings are in your applications. And if you can get them easily now, that's not a problem. If you don't get them, no issue. But if you do, bonus. The interview. The interview is an opportunity for you to sell yourself, to make yourself look amazing. Problem is, a lot of us don't do this. We don't realize how much we have done. This was me a couple of months ago, because I thought I had minimal points until I then listed everything that I've done. And then I thought, wow, actually, in my portfolio, I have quite a lot. When you do your interview, it's mainly split up into at least 3 stations. So they look at your portfolio and ask you questions. So if you've put an audit in there, they'll ask you about the audit. And the main question is, what did you learn from this audit? So it depends what the whole audit was about, but they will ask you about it, for the main question being, what have you learned from it? So it doesn't matter what it was in. If it's in a completely different specialty, it doesn't matter, as long as you've done an audit. Clinical scenarios. So again, A to E assessment. And if you go step by step, you can't fail. and ethical scenarios. So know about confidentiality, know about Gillick competence, know about all the ethics about medicine, because that will come up. And just make sure you don't raise any red flags. As in, if somebody is asking for a patient status and their illness, and they've specifically said they're not allowed to, and you do that, don't do it. That's a red flag. Yeah, that is the end. So Mohsin, I will give this back to you. And then we can ask questions. Make sure you put your questions in the Q&A box. And then I can start answering them. There's also a feedback form, I think.
Yeah, I'm just going to share that now, actually. I'll do that quickly. 1 second. It's easy. Where am I? Here we go. Okay, cool. Right, so feedback form, for those of you who don't want to click on the link, just get your phone out, get the camera app open and wave it around with this QR code. It should take you to the feedback form. Alternatively, you could see the answered questions and it should be over there. So please do fill that in. We do love feedback over here. It really does help us. First of all, a big thank you to Dr. Khaliq. Thank you so much. Great talk. I think a lot of it was just personal digs at me, because I just remember doing placement with her and, like, you know, some of the places I was going wrong, like, you know, just the experience of it. And it really is like, it's tough work, because I remember I was in there for 3 weeks and you really feel it on your feet. I think that's the first thing you notice, like, you know, you just start seeing your arches go. So I was always constantly like looking for places to sit down. And then I think on my very last day, I've been on this ward for 3 weeks at this point, and I just see this room and I'm just like curious for 3 weeks what's inside this room. And I finally go in there, and turns out it was like a full-on staff room with sofas and a microwave and a kettle. But like, these doctors work so hard, like, in 3 weeks of being there, nobody actually went in there and took me in there with them. So I had no idea that existed. I was just like, why did nobody tell me about this? So it's really tough work. And also a big thank you to Lectoria for being our sponsors. If you do fill in the feedback form, you'll get your 50% discount code and a certificate for attendance. Right, I'm going to start hitting the good doctor with questions. I've had quite a lot messaged to me and emailed to me. I'll start with the ones here first. Okay. So this one's pretty interesting. Are you able to choose your rotations for IMT training?
Yeah, definitely. So when you apply for IMT training, and the first thing you do is apply by region. So you pick the area you want to go into. Once you've been accepted to that area, they list out all the different rotations that there are available. More often than not, it's definitely going to include what you want. You pick from the rotations available. So you can't say, I want to do cardiology and then respiratory and then medicine, gastro, because more often than not that is available, but you get to choose what order you do the rotations, and some will offer more than others. But yeah, you definitely get to pick what rotations you want. As long as your ranking is good, you'll be fine.
Lovely. So somebody asked this question. I think I get this a lot. It's, what is the best specialty start for someone who has never worked in the NHS, so it's easier to transition into the UK? From my experience, I can't really put a finger on what's easy or not, but I think I've heard a lot of people say stay away from the AMU or the A&E for your first rotation. Unless like you're feeling really confident. I know somebody who picked it for their first rotation, they regretted it massively. So I think I've seen a lot of people go for psychiatry. What would you say, Dr. Iman?
I mean, it's hard to answer because it depends on the hospital you're working in. I definitely would not start in an F1 in A&E. And actually, as an F1, you can't start in A&E. You can only do it from F2 anyway. So that one's an easy question. AMU is actually really good to start on. You are surrounded by loads of seniors. You're surrounded by loads of doctors, actually. You're more well-staffed in AMU than you are in any other place. So it's not a bad place to start. But actually, all the specialties that you do are going to be similar. If something like respiratory or gastro are going to be very busy, I give you that. So maybe don't start on those ones and like specifically. But any specialty, it kind of depends on the team and it depends on the hospital. Because if you're working in a DGH, so a hospital that's not in the main city, that's quite far away and not as busy, then any specialty will do. But yeah, the huge acute specialties you can keep away from for the first rotation. So like your respiratory, your gastro, sometimes even cardio if you're a cardiology center. So it kind of depends on the area you're in, the hospital that's available. But I mean, I wouldn't necessarily pick which specialty to start. You can start really chill and do geriatrics because then you get an idea of all of medicine. It's quite like varied. You get to see all sorts of specialties within geriatrics.
Absolutely. This next one, I'm just going to get out of the way because I'm sure a lot of people are curious about this. So somebody asked, the salary, is it that bad? Like, are you still able to pay your bills without having a second job? I'm really interested in internal medicine, but I'm more worried about my bills.
Bless you. So your pay when you start is not great. So you will have your minimal wage will be as long as so when you're an F1, I think it's around 26k, so £26,000 in a year, which I think amounts to about 1,800 in a month or something like that. This is not counting any extra locums you do whilst you're working. So if you're an F1 and if you're really worried about your bills, what I would advise is more often than not, you can pay your bills. You'll be tight, but you can. Because you're earning more than most people, but you're not earning what you should be according to the amount of jobs or work that you're doing, which is unfortunate. But there are ways you can earn more money. So you can go for locum shifts. So locum is a big lucrative area in medicine. So like I said, I had a guy who was in my year group when I was in F1 and he's currently in his F5 year or F6 year. So he did his F1 and F2 and he's remained out of training just doing locums every year. So you can even do locums during your training. So say, for example, you're working Monday and Tuesday and you have Wednesday off. You can choose to do the Wednesday as a locum. So there's always ways for you to make money. It's just if you're willing to work on your off days or not. And again, your money gets better the further you go, the more you progress in your career. So you earn more in F2, then you earn more as an IMT1 and a 2, and it just gets better and better. But unfortunately, you start off quite basic, and that's the UK government, unfortunately.
Absolutely. And I think that's the thing. I think the other thing is I wouldn't get ahead of myself and put a mortgage down or anything. Probably not a good idea. I see a lot of people jumping into big financial commitments as soon as they start working. And I mean, eventually you'll be making decent money, but won't be for a while, I presume.
Yeah.
I don't think you'll have time for a second job, at least.
Yeah, you won't. Especially when you're starting as an F1 and F2. When I first started, I was in this horrible cycle where I was waking up, I'll go to work, eat, sleep, repeat, work, eat, sleep, repeat. And it was almost impossible for you to fit anything in, which is why I'm so big now on telling people that you need to maintain a work-life balance, because I wasn't able to do that to begin with. And I found that out the hard way. So I don't think a second job is going to cut it, but you can do locum shifts within your own hospital. You can even do like just the evening shifts, like a 2 or 3 hour after your normal day, if it's available. So locuming is probably the way to get more money. You will be able to pay your bills. But I think the thing is that different people are in different times in their lives. So even if you're a junior doctor in F1 and F2, you might have a family and like 3 kids that you need to take care of. So I understand your question that you can make money, but it becomes more lucrative later. And there is a scope for private practice, but you can only do that once you're a consultant.
Yeah, absolutely. Somebody's asked this question twice, so I'm just going to address the elephant in the room. I have passed CBSE class 12 from Oman and I'm a US passport holder. What process do I need to go through to study medicine in the UK? Apply for medicine in the UK and sort out any visa and passport issues you might have. Will I get any favors? You're probably best contacting UK university about that. Also, can international students do internships in the UK? I'm not too sure about internships, but I'm pretty certain you can do electives as long as you have all the visa and immigration documentation sorted. They generally tend to accept people, because I went in as an international student myself for my elective. I think the only condition they put forward was you had to be a final year student, and they gave them priority. That was about it. Okay. Doctor, so somebody asked, what did you mean by primary care is changing?
So I think a lot of people think GP is the chill life and it's the relaxed life and you only work 9 to 5. That's not the case, because as secondary care, so secondary care is the hospital medicine side of things. So as in hospitals, A&E, everything's struggling at the moment because the numbers are just immense and primary care is not able to keep up with the current existing appointments. So what's happening is they're opening on longer days. So for example, my local surgery is open Monday and Thursdays 8 to 8. So it's not your chill 8 to 5 anymore. Some GP practices are open on the weekends as well. They're not doing you're not doing night shifts and stuff, but it's changing in the amount of workload because you're trying to reduce the workload in secondary care. And the only way you can do that is by improving primary care. If it's not an emergency, you shouldn't be coming to hospital or to A&E, but they can't make a GP appointment. So the only way you do that is by doing more hours and getting more GPs. So that's what I mean.
Yes, I completely agree, to be honest. When I was in Essex, I was in the hospital during the days, and as soon as I finished, I went straight to the GP, and I was there right up until like the late hours in the evening, because it just never ends, and there's always something to do.
There's loads of paperwork. So even if the surgery's shut, you're still staying behind to look at all the referrals or the discharge letters that come from hospital as well. So it is changing. You just have to watch that space.
Because literally, I remember one of the GPs I was working with telling me 9 to 5 is the hours for the patients, not for the doctors. That's literally it. Do we need to do the PSA as IMGs? No, apparently not. I think you still need to do your SGAT, but you don't need to do your PSA, which is super surprising. I only found out a couple of weeks ago. Oh, okay. So any regrets about choosing internal medicine or cons you realized after the fact?
I don't regret it one bit, if I'm honest. I don't regret it because I was very open-minded when I went into training, and I didn't decide I wanted to do medicine until right near the deadline was coming. I thought, let's go into medicine and try it. And I don't regret that decision. The cons, like I said, it's very heavy workload. If you can work around that, you love your job and you find solutions to the problems. Like if you can't make your kids or your brothers or your family's birthday parties and whatever, like family function, weddings, then like you need to be really organized. I've had to become organized. I've got this big calendar on my wall because I have to somehow be able to be organized enough to figure out when my off days are, and try to put my social life around that. So I don't regret it, but I'm not going to lie, it is hard work to get around it, but I would never change it. And actually, another thing, go into less than full time if you're worried about the hours. So you can do 60% or 80% of your training. So you, instead of working Monday to Friday, you can do just Monday to Wednesday, so 3 days a week. But it just means your training will be a bit longer. So there's an option for everyone. You just have to be aware of those options.
Absolutely. Is there any way to prepare for interviews regarding clinical and ethical scenarios? Any resources or websites as such?
There's loads. All you need to do is a Google search. There's also a book available. I think it's called like 1,000 interview questions. The best thing that I would advise is getting to contact with a doctor or even a final year medical student. It depends how confident they are, but get into contact with those guys and practice, because it's not necessarily you have to have the knowledge, and when you're in med school, you have the knowledge. But I think the most important thing is knowing how to articulate the answer. And that's only done by practice and actually honest feedback. So there's loads of courses available. You don't need a course. Some people do interview courses. I don't think I did any interview courses, but I mean, they cost a lot of money. If you've got the money, go for it. But I would just get into contact with a doctor and practice with them, because I'm sure they'll never say no.
Yeah, I completely agree. Okay. Is is there any protocol for lunch or when you need to leave the ward?
Absolutely not.
You have no. So
No.
do you have to let any of the doctors know or the staff or let them know if you're back at a certain time or leave a number, so on and so forth?
So when you're a doctor, nobody is there to tell you. Like when you're a student, you have a schedule, right? As a doctor, you're an adult now, and you have to plan your own time. So again, some people will be very bad at this to begin with, but you learn the hard way. When you start becoming hangry and really, really, really agitated because you haven't had any food, you'll realize that it's not worth it. Um, so you don't have lunch times that are set in your schedule. You have to take them yourself. So you can leave the ward. Most often you're holding a bleep. So it's a little like square pager type thing. And if the nurses need to contact you, they'll contact you through the bleep. If you don't have a bleep, you can give them your mobile number. You have to leave the ward. If you don't, I'm telling you, in the middle of your lunch, if you're sitting in that staff room that you mentioned, Wilson, if you're sitting there, a nurse will come in and say, oh, can you prescribe paracetamol or can you give me a laxative? And you will not have your lunch. So my advice is get off the ward for your lunch and take at least 40 minutes for your lunch, because otherwise you're not going to get a break for the rest of the day. If you have a good senior, because this is what I try to do for all my juniors, is we all go for lunch together, because it allows you all to kind of charge down and get away from it, because it's nice to at least talk about something that's not work or patients. If you can't do that, you can go in turns, it doesn't matter, but make sure you take your lunch, and you have to do it yourself, because no one's going to be like, oh, it's lunchtime, guys. There's none of that. There's no bell that rings that says it's lunchtime. You have to do it all yourself.
Yeah, I think that was the first question I actually asked Dr. Khaliq initially on my first day, because I was absolutely starving. I went up to her and I'm just like, what time is lunch? And she just looks at me, she's like, whatever you want. Are you hungry? Yeah.
You can take
Lunch is
lunch at
now.
11. You can go have a coffee break if you want. If you've done all your jobs, there's no problem taking it any time. But don't expect someone to say, guys, it's lunchtime, because not everyone does that.
Yeah, no, quite the opposite actually. No, absolutely. Okay, so okay, this one's actually quite interesting. So, hi, I am a mature student, also a retired teacher. I'm in second year of my medical studies. I just worry if any hospitals will give me a job when I complete my degree, as they may be looking for very young and energetic doctors. I don't know, it just hits me at times.
How old are we saying?
No age given, but mature student and also a retired teacher. So I'm
Right.
guessing that.
Age does absolutely not matter. Okay. Like I said, people are in different aspects of their lives. Some people have done 3 degrees before they come to medicine and become a doctor. So age does not matter. In fact, they'll probably look at you and think you're more senior than you are, which is common misconception that I see with lots of people. I once had an F1 who was, I think, 51. And obviously I'm the senior, but they would look at him as he was a senior. So age does not matter. It was all in your head. So if you allow it to be a problem, if you feel insecure in your age, people will treat you differently. So you just need to be confident. And as long as you're able to keep up, you'll be fine. Because like there's people who are like 65 and are F1s, you know? So you will never have an issue with somebody thinking you're old. Even if they think you're old and what? You're still doing that job. It doesn't mean anything. Just be confident and don't second guess yourself, and you might be more wise in terms of experiences, and you can use that experience as a teacher or whatever you had done before to help you become a better doctor. So don't worry about age. Definitely
Absolutely.
not an issue.
I think no matter where you are, the people are always going to find a way to criticize you, or at least you feel criticized for something. Because I remember, not for somebody who looked, who was a mature doctor or mature student. It was I remember going up to a doctor, and who I thought was a medical student because he looked so young. And I literally just sort of went over to him and I just budged him and I'm like, are you also doing an elective? And he looks at me really confused because he turns out he was the cardiology reg. And I just looked at him. I swear the guy looked like a day older than 24. So it goes both ways. And
It definitely does. I had when I was doing orthopedics, I had a guy who was post-op say to me, "Oh, are you a student?" And I said, "No." He goes, "You look 16." And then I thought, mate, I'm coming here to make sure you can go home, but now you can stay a bit longer for that. So like it goes both ways. But again, you don't let it phase you, because at the end of the day, you are the doctor. You've gone through 5 or 6 or 7 or whatever years of med school of your life to get that accreditation. It doesn't matter how old you are, you have the knowledge.
And I think I think it puts you at a certain advantage as well, because obviously being a mature student, that maturity is over there, it's in the name. And I think that way it becomes a lot easier to talk to patients. At least, you know, some of them might trust you a bit more than younger students.
And you don't take crap from nurses either. So when
Yeah,
you're
but I've literally went up to patients and like they've just looked at me. They're like, "Nope, like, I'm not letting you take blood," because they look at me. They're like, "This guy's young, probably unexperienced, whatever." So I think it definitely can work to your advantage. Again, like Dr. Khaliq said, is how you use it and try and put it to your advantage. And whatever limitations you put on yourself are really the only ones that exist. I think a lot of people are asking about applying for electives as well. And I think that's obviously a major issue with a lot of students. And it is really, really possible to get in, but I think with COVID, it's made things a lot more difficult. At the moment, I'd say just start contacting hospitals and start inquiring about it, and just keep pestering them. Even if it's down the line, even if it's in a year's time or whatever, because a lot of them are very, very happy to reply to you saying, "Oh, we don't have anything right now." But not a lot of people. I think what I did different was I emailed back asking them, "When will you have something?" And I actually got a reply. So they were like, "Oh, how about in 8 months?" And I'm like, "Cool." So I think that's the thing. Just keep chasing up and just keep emailing them, because the one thing they can't do is ignore you. They can say no to you, but they can't ignore you. So you'll definitely get an answer. And if it's no, then just move on. There's plenty of hospitals out there.
Yeah, there's thousands of hospitals in the UK. I'm sure one of them will give you a spot. Just continuously keep emailing, because obviously as medical students from a UK school, they like you're attached to that hospital and you get placements. It's not hard. But for international students, you guys are coming from a different aspect. As long as you've got your visa sorted out and other things like that, it shouldn't be an issue. But you just need to hound these people and hound all different hospitals. It doesn't matter which one, just get one in a UK hospital.
Yeah, absolutely. Okay, this is going to be the last one. I was going to skip over this, but I feel bad. So, I'm a fifth-year medical student considering leaving medicine. Long hours, exhaustion, low pay. Feel like there's nothing to look forward to. I don't really know what to do or how to approach this.
You're not the only one. A lot of people leave medicine. A lot of people leave medicine, and it is because of those reasons. And like I said, medicine is not never the easy option. I don't think anybody goes to do medicine because it's easy or because the pay is good, because none of those things are true. Um, if you're doing this when you're a fifth year medical student, there's 2 ways you can look at it. A is this is probably the best escape route you can have, because you haven't even started working yet. If you don't enjoy medicine, I don't think you can continue it as a career, because one of the most important things that I found that allows me to continue being a doctor is that I enjoy it. If you don't have that enjoyment factor, something's wrong and it might not be the career for you. Because medicine's only going to get harder when you start working, and you're not going to have the same securities you do as a student after you leave medical school. So I think you need to be honest and frank with yourself and say, do you want to do medicine? And then if you have the answer to that, the other option is, because ultimately you have to do the F1 or the F2 trust grade post. So you will still have to work in a hospital. You only get the escape later on in life when you say, okay, I want to be a GP, or I want to do occupational medicine, or I just want to do clinics. Like those options come later on, but you still have to do hospital medicine. And if you're struggling and getting exhausted with like medical school, either A, find a solution to try to work around it. Like what is it about the long hours that is like, can you kind of condense those? Is like a group-based study better option than you just studying in hours into the night? Like try to take a step back and simplify what's going on in your life and see where you can make changes, because like I said, if you don't love medicine, that's probably not one of the ways to go into medicine and continue. But you can do so much with a medicine degree. You can do so much with a doctorship. You don't need to necessarily work. You can go into research. You can go into like pharmaceutical industry as a doctor and work in the clinical field. Like, you just have to get your GMC registration, obviously. But after that, just don't do something you don't enjoy. That's one thing I've learned in life.
Yeah, no, I couldn't agree more. I mean, I'd say like the fact that this person said they were a fifth-year medical student, I would at least encourage them to see it through. Because
finish it, do your F1 year, because it might change. You might love the clinical aspect of it. Like, but you'll learn this once you're on the job, is what I'm going to say. Like, but don't do something you hate, because you'll regret it for the rest of your life. But don't just give up straight away either.
Absolutely. But yeah, no, definitely. I'd say spend some time in the hospital and see what it's like over there, because you don't really get a lot of satisfaction from passing an exam like you would helping a patient or helping somebody get better. Not quite the same things. I'm sure both of them make people happy, but I think once you get in there and you actually see yourself using those skills and making a difference, even if it's like a small, minute thing, sometimes that's enough to stay with it. And at least, you know, looking at it from an external perspective, for me, that's pretty much all the motive is, because like you said, there's nothing else. It's exhausting. The money's not great. The hours are long. You're making a lot of sacrifices. So I think a lot of people do turn around and end up being happy with the fact that, oh, okay, I'm making a difference to someone's life. And if that's not enough for you at the end of the day and you still want to do something, then by all means, it's never too late to start or change careers or change paths. So yeah, you're going to live a short life. Do something you really enjoy, I suppose. But before we finish off, again, I really want to thank the good doctor. Thank you so much for being here. Really good talk. Got through a lot. I think we helped quite a few students figure out some dilemmas here. So
do medicine. If you pick one thing, do medicine.
That's honestly the most biased thing I've ever heard a doctor say. Yeah, do your research is what I would say.
Go into your career of choice open-minded. Know what the good things are and the bad things, and make an informed decision.
Definitely. I think the one thing I really did that helped me a lot was I started figuring out what I don't want to do.
Yeah, definitely.
So I was very eager in my elective to spend time in wards where I was sort of suspicious of, and I'm like, oh, I'm not sure if I want to work in here. So I went to cardio, spent a couple of days there. I know I don't want to become a cardiologist now. Like, it's completely off the reservation. Neuro, just the same. Surgery went out the window really quickly. I'm still not sure what I want to do, but I have a rough idea and I know what I don't want to do. So I think that's also a way to approach it. But everybody, please do fill in the feedback forms and let the doctor know, let us know how it was. It'll take you 2 minutes. It does help us a lot. And if you guys do have any questions, give us a follow-up email. You should be able to find it on the website. That's all. Any closing comments from Dr. Khaliq?
No, man. Thank you, everyone, for attending. That's your first step into seeing what medicine is like and choosing if medicine's for you. Don't let anybody tell you otherwise, because I think there's lots of negativity around choosing internal medicine or becoming an internist or a physician, whatever you want to call it. But if you love it and if it's something that you want to pursue, do it. You don't need to have a certain personality type. You don't need to be a certain age. You don't have to come from a certain country. Anybody can do it. And like, there will be hurdles and barriers, but like, pursue it, continue, and good luck.
Amazing. Thank you all so much. We will see you next month. Thank you again, doctor. Everybody, have a good evening. Take care.
Bye.